I just finished doing your anatomy and nutrition, anatomy and physiology and nutrition. That's come up and told me you couldn't read it in my computer, but it is in the process of trying to download on YouTube. So we will see how that's going to work with our YouTube. Well, let's try to get this one done. We're going to go through chapter 14, which is the nursing care of the family during pregnancy. This one is a little bit odd, and it's thrown a lot of things in here that were in other chapters before, and I'm not sure that it makes a whole lot of sense to me, but since you aren't aware of the changes, it's not going to be any difference to you whatsoever. So first of all, they want to talk about the diagnosis of pregnancy. Signs and symptoms of pregnancy, how to do Nigel's rule, and how to do the estimated date of confinement, birth, or delivery, however you want to say that. So usually our physical cues of pregnancy are always a little bit different than what it is with anything else. Some of us feel nauseated, some of us feel bloating, some of us feel tenderness in our breast, the nausea, the vomiting, all of those things that are signs and symptoms. And so we've already talked about the presumptive signs and the probable signs and the positive signs. So go through those and review those if you don't know them, because I'm definitely going to have them on the exam. Nigel's rule is in your little box up there, in box 14.1, and basically how to figure out your estimated due date, or how to figure out an estimated time of birth or date of birth, however you would like to say that. The EDC that we used to say, estimated date of confinement, sounds a little bit harsh, so that we decided we didn't want to call it confinement because it sounded bad. So we changed it to date of birth or estimated due date. So how we're going to figure this out is we're going to take the last menstrual period, the first day of the last menstrual period, and in your example it gives you December the 10th through and in 2015. So our month is 12, our date is 10, and our year is 2015. So to figure out the estimated date of birth, we subtract 3 from the months, which gives us 9. And then we add 7 to the day. So our estimated date of birth is going to be September the 17th. Very simple, very easy. So be sure you look at Nigel's rule and you know how to do it, because that will definitely be on your exam. So let's move on to adaptations maternal. We have adaptations maternal, paternal, grandparent, sibling, and all of them pretty much follow this same thing. Acceptance. How does mother show that she's accepting pregnancy? A lot of times you are like hit with a brick stone. I don't want to be pregnant. Even if you're trying to be pregnant, it's kind of like, oh, I don't think I want to be pregnant, because it's not a step you want to take backwards. So the first step is being able to accept the fact that, hey, I'm pregnant. And then when you identify with the mother role, the mother's going to say, I'm going to be a mom. So you're identifying with the role that you're going to be a mother, and you start accepting that you have to deal with a mother role. You're going to have to take care of this child. You're going to have to raise this child, instill in them values that you do. Then you've got to reorder your relationships. You have a different relationship now with your mother. You're going to get closer to your mother if you had a good relationship with your mother. If you had a bad relationship with your mother, you may seek someone who would be in that mother position. Your relationship with your significant other is going to change, because you now are pregnant. You harbor a life inside you, and you're going to be looking inward toward the baby. And so sometimes it's a little bit hard for dad to accept, or your significant other to accept, that relationship is going to be reordered. And of course, you have to establish the relationship with the fetus. A lot of times it's difficult to even identify with the fetus unless you hear the heart tones or you see the baby on ultrasound. And so then you start establishing that relationship with your fetus. And it goes through 3 phases. You know, you say you're pregnant, and then in phase 2, you accept the fetus as, I'm going to have a baby, and then in phase 3, I'm going to be a mother. So it goes through all those phases. And dad's phases are exactly the same, except it's, I'm going to be a dad. And then, of course, when you're preparing for birth, you're going to seek out others, seek out prenatal birth classes, You may be anxious. This may be an old thing for you, but it's a first-time baby. You may suffer from some severe anxiety and things. You're going to have backaches, frequency of urination, all these discomforts that we're going to talk about. By the time the baby's due, you are more than ready to have the baby and get it done and get it over with. So paternal goes through the same exact things, identifying, accepting that he's, you're going to have a baby. He identifies with, I'm going to be a dad. He has to reorder his relationships. Perhaps he gets closer with his dad. He has to reorder relationships perhaps with people who are single that he's no longer going to identify with, and he's going to seek people out who have children. And of course, he has to establish a relationship with the fetus as well. And going through those phases of establishing that, men prepare for fatherhood the same way that, that moms prepare for motherhood. They go and become, establish those relationships with the fetus. Then they also are preparing the birth. Of course, a lot of things they're worried about is getting mom to the hospital in time. I'm going to have to deliver the baby, and so forth. Then we have others. We have lesbian parents. We have homosexual parents. We have siblings, and we have grandparents. The non-pregnant partner, if it's two females, they may have a little bit of jealousy going on that one's pregnant and one is not. If it's homosexual partners, that's usually expecting a baby from a surrogate. They still have to do all these adaptations. So it's a little bit different with that non-pregnant partner depending on what sex that partner is and how they actually view the pregnancies. Siblings, of course, always have a little bit of jealousy going on. You can alleviate a lot of that jealousy by getting them involved with the pregnancy, letting them develop relationships with the fetus as well. Different age groups, as Mrs. Candler has taught you throughout, the difference between an infant, the toddler, the school age, all of those siblings will have different reactions. Your infant's really not going to pay much attention to whether a baby's coming into the household or not, and they are not at the point where they can feel jealousy, whereas a toddler may not really like to see this change going on. And by the time they're they're older, school age children, they may be clinically interested. So it depends on what age they are and how they're going to, as to how they're going to adapt. Grandparents usually adapt very well to grandchildren, but they do go through a process of adaptation. Usually they're very excited, but if they're not very excited, you don't really want to involve them in the care, but they actually can provide a lot of support during your pregnancy. The care management that we have of pregnancy, of course, we want our goal of prenatal care. We want our patients to get good prenatal care because good prenatal care has shown to have better outcomes, especially if they get that prenatal care in that first trimester. Then your book goes through about Caucasian, 75% of the United States women get prenatal care. Non-Hispanic African Americans, non-Hispanic Native Americans, and so forth that do not seek out prenatal care. Usually the reason they don't is because of cost or lack of insurance, child care, lack of culturally sensitive care. Providers may prevent some from going, discrimination based on sexual orientation. Several of those things are barriers to our outcome. Immigrant women who come from cultures where prenatal care is not emphasized don't seek prenatal care. We have a higher rate of maternal and fetal complications with these particular women. Since we have advanced practitioners and certified nurse midwives, we have a lot more venue for the patients to choose from. Home visits from nursing, even nurses' aides, are going to aid in the reduction of barriers and help with the outcomes of our prenatal care. We have traditionally always used the same prenatal visit schedules for our pregnant women. I don't see a whole lot of difference between the traditional and the centering pregnancy prenatal visit schedule. Box 14.3 puts them side by side for you. First visit within 12 weeks, same. Monthly visits, this one says every 4 weeks. Monthly visits to me is like every 4 weeks. So that to me is basically the same. And then every 2 weeks from weeks 29 to 36. And the new one just does every 2 weeks, whereas in the traditional, once they got 36 weeks, you usually see the doctor every week, which is basically most doctors are still going with the traditional model versus the centering pregnancy. There not been enough, this hadn't been around long enough to actually realize what they are. Group prenatal care is a little bit, I don't know that very many women in the Southern culture would go for this, but there are in cultures would accept this. Going to have your prenatal visit and then having a session with a group after the initial visits for an hour with a group of women in the same gestational pregnancy period that you're in for an hour to just talk about different. So they go in for their prenatal visit, which would take however long that prenatal visit does, and then after their prenatal visit, all these women would meet for an hour for probably 10 times. And they usually are encouraged on talking about specific issues such as discomforts of pregnancy and getting prepared for labor and birth. Preconception care, I think, is a wonderful thing. It's a most important contributor to good pregnancy outcomes. If we can get healthy lifestyles, then we should have healthy babies. So what are we going to do at that initial visit? When you go to your initial visit, you almost need to pack a lunch. Your initial visit takes a long time. So if you're taking a family member with you, be sure they are aware. If your husband's going with you, he needs to be aware. It's not going to be a 10-minute get in, get out. The initial visit, they've got to get all of the information they need. It's just much like you did your review of the systems and you did an interview. These are all going to happen at this initial visit. Hopefully, you're going to establish a therapeutic relationship with your patient. You are, of course, most women come to an OBGYN because they think they are pregnant, but we still want to say what's the reason that you're here. It may be that they have another complaint and we find out that they are pregnant. Their current pregnancy, if they have any issues with their current pregnancy, nausea and vomiting might be a great concern for them, and so going over the symptoms with them could help. You want to know all of their age at menarche, their menstrual history, any type of contraceptives they use, sexually transmitted diseases, anything to do with the reproductive. Health system's very important. If they've ever had any issues with their health, such as diabetes, hypertension, epilepsy, you need to know their immunization, allergies, any type of medications that they're taking. If they've had any surgical procedures before, had any problems with any of the anesthesia, any of the information you need to collect during your health history. And of course, nutritional history, you want to ask them maybe about a 24-hour recall on what they eat. You want to educate them on the pica that we talked about. You want to tell them how much weight gain they should be having, about their calcium intake. You want to discuss all those things with them. It's very important to ask them if they are taking any herbal supplements or any other type of supplements, if they're using their caffeine use, if they are have any alcohol use. It's very important that you do that because some of those substances cross the placenta. We need to know their immunization record, but if we don't know their immunization record, of course, we are going to draw a titer to see if they have immunity to, especially to varicella and rubella. Those are two things that we really want to watch for. Now we're even concerned with pertussis And of course, hepatitis B we've been concerned with for a while. Family history is very important in establishing what might be going on with you, and your family disorder might be affecting you. Social, experiential, excuse me, I said experimental earlier too. Experiential and occupational history. We need to know all of this. Did you plan your pregnancy? Do you want your pregnancy? Are you happy about having a baby? Who's your primary support person? Do you have adequate support? Do you have good relationships throughout your family? What kind of preparations are you making? Who's going to take care of any children you have during labor? How's your finances? Do you need any educational? Do you need prenatal? Do you need to go to prenatal classes? All these things are questions that you can ask and be able to address them, and this will help them deal with possible changes to their lifestyles when the baby comes home. Always assess for risk of intimate partner violence. Whether it's two women, male, female, two males. Usually during pregnancy, violence escalates. He may not have ever hit her before, but when he found out she's pregnant, she may have gotten hit once, twice. So you need to find out if there's a risk. And always be sure that they know they need to have a safe plan. They need to always have a place where they can go to where they can be safe. And of course, you always do a review of all the systems. Any type of pre-existing or concurrent problems that they may have and of course, their mental status. Okay, physical exam. We're definitely going to do a physical exam. This is where I told you we would get to looking at laboratory tests. So, we've talked about in the physical exam, be careful, don't put them in a supine position. Always tilt that pelvic. If you're going to do an ultrasound, make sure they go pee first. If you're going to do a pelvic exam, make sure they go pee first. That keeps them from being uncomfortable. If you're doing that supine position for the lithotomy position for the pelvic exam, tilt the uterus so you can avoid that supine position. The laboratory things that we're going to do are listed up in Table 4.1. You need to know that during that first visit, we're going to do an H&H. We're going to do a blood top and an RH. We're going to do a rubella titer. We're going to do a urinalysis. We're going to do a pap smear. We're going to do a urine culture. We're going to do cervical cultures for possible STDs, and we're going to do blood work for possible STDs. And it tells you that the GBS is not going to be done until they're about 35 weeks pregnant, and we're also not going to start testing for glucose until around 24 to 28 weeks, and because that's when we start seeing resistance to the insulin and glucose going up. So all of these things are done in that initial visit. And then, of course, our follow-up visits, we usually will do a urinalysis and fetal heart tones and weights when they come in to make sure the baby's growing, maybe fundal heights. Our interview that we're going to do, we're going to address their emotional well-being. We're going to, and it depends. The first trimester, we're going to talk about certain things. Second trimester, certain types of things. And third trimester, certain types of things. So depending on their trimester, depends on actually what we're going to be teaching them about and what they need to identify with. But these are things that we normally always do when they come to their interview. We do a fetal assessment on gestational age. We usually do heart tones and we do fundal height. And we may or may not do some laboratory, usually urinary urinalysis. The physical exam, of course, we're measuring their blood pressure in the same arm at every visit. We may be doing their urine, and we may not. We always want to make sure that we're measuring the fundal height. Remember I told you per centimeter is per week. Now you have a box on 314 that gives you signs of potential complications per trimester, and that's important that you know that. Some of the things that happen in the first trimester are not significant in the first trimester, but would be significant if it persisted in the second or third trimester. So you want to try to just kind of watch out for that. Gestational age, if we know their due date, we will sometimes do an ultrasound to confirm the due date is about right. We want to, of course, write down the date that they felt first movement, always the fundal height, and fetal heart tones, of course. We usually do those with Dopplers, and usually, like I said, when they're less than 12 weeks, it's very hard to hear them because they're in the pelvic area. After they become after the uterus becomes an abdominal um, organ, then they're a lot easier to hear. And most of the time, you use the Doppler. The Doppler is a lot easier, and then everybody can hear it, and it makes everybody feel better. Fetal status usually considers fetal movement depending on the gestational age. If they're 12 weeks pregnant, you're not going to um, be saying, oh, that's terrible. Because if they're not feeling the move at 12 weeks, that's perfectly normal. If at 20 weeks or 22 weeks they're not feeling fetal movement, then that's usually associated with fetal death. If they have been moving and mom says they haven't been feeling the baby move, then that's really horrible. You always want to instruct them to come to do fetal kick counts, even though there's really not any set time for fetal kick counts. Usually 4 or more in an hour is considered reassuring with that. Fundal height, we talked about fundal height already in another, usually from gestational age. At 20 weeks, it should be right at the belly button. 18 weeks would be slightly below the belly button. And so you go by this, your paper disposable tape is what you really need to use. And of course, be sure their bladder's empty before you measure because it can displace where the fundal height is. We do a lot of different types of screening, laboratory tests that are done. In follow-up visits, they're pretty limited. Like I said, usually urinalysis, but sometimes we will do multi-marker screenings for Down syndrome, trisomy 18, neural tube defects, gastroschisis, and the first one's usually does the 2 biochemical markers from 10 to 13 weeks. And then we'll do one between 15 and 20 weeks, what we used to call the alpha-fetoprotein, but we have now added another marker to that one. So it actually has 4 tests in the alpha-fetoprotein when we do the alpha-fetoprotein, and usually do that between 15 and 20 weeks, 16 weeks being your ideal time to do that. So they now have a non-invasive prenatal testing they can do. That will is a genetic test to identify fetuses at risk for trisomy 21, 18, 13, and sex chromosomes. A positive NIPT should always be followed up with an amniocentesis, which is the bad thing about all these things is it's always has to be followed up with something else and followed up with something else, and you end up having a whole lot of testing done. Because the results of the first test lead you to another test that leads you to another test for confirmation. So, GBS, Group B streptococcus, is something that is tested only between 35 and 37 weeks. Again, the gestational diabetes is tested between 24 and 28 weeks. So our nursing interventions, most of our things with pregnancy, education. We have to educate them on self-management. They need a lot of information because this is a whole new ball game for them. Unfamiliar territory unless they've been pregnant before. Especially if they receive a lot of advice from people who don't know what they're talking about. Expected maternal and fetal changes. How, mom needs to know about the growth and development of the fetus. That's why we went over fetal development. They want to know, when does my baby hear? What is my baby doing now? How big is my baby now? So those are some things that we should be teaching them on. Nutrition, of course, we just went over that. It's very important that they maintain their proper weight gain and maintain their proper nutrition. Personal hygiene. Remember we talked about how they would have excessive sweating. So they need to know that that's normal and be prepared for it so that they don't think there's something horribly wrong with them. And sometimes those hormonal changes can also cause them to have the sweating. Prevention of urinary tract infections. We talked about how easy it is to get these because of the ureters becoming floppy and urine stasis in the pelvis and in those ureters. So we need to teach them signs and symptoms of urinary tract infections, such as frequency, urgency, dysuria, dribbling, hesitancy, even bleeding. So we need to teach them all those things, and that it can actually put them at risk for preterm labor, and they need to get their antibiotics started and maintain their antibiotics. Hand hygiene is very important to teach them. Sometimes they don't know they should wash their hands so often, but because we always wash our hands, they should wash their hands before and after urinating because there's such high risk. If they're coming out of the yard and their hands are dirty, they definitely need to wash them before they urinate. Need to teach them front to back wiping. Wear cotton underwear. Avoid bubble baths. Don't wear tight clothes. Be sure they consume enough liquids. Be sure that they don't hold their urine for long lengths of time. And of course, teaching them Kegel exercises can help them with possible incontinence later on. And cranberry juice, of course, is still offered as an intervention to help prevent that. And it is dependent on that they have to do this every day and they have to drink it every day. And those Kegel exercises are wonderful things. You can do them anywhere, anyhow, any place. You have to do a lot of them for them to be effective, and it will help them maintain their ability to hold their urine. Preparation for breastfeeding. They should have their breasts examined to see if they have inverted nipples. You want to check them to make sure whether or not they do. Inverted nipples need a little bit more help. We need to try to get their nipples to evert so that the baby can grasp a hold of them. There's a breast shell. They show a picture of that patients can wear to try to help pull out the breast, but as a certified lactation counselor, I can tell you that doesn't work very well. The best thing is to put the baby at breast and let the baby pull the nipple out itself. It's just a lot of work trying to get the baby to do that because babies are creatures that want instant gratification and they want it now and they want that nipple to be perfect and they want it to fit in their mouth and they don't know that sometimes it takes a while. They're not born knowing those things. This is a time during their pregnancy that we can advocate for breastfeeding, but we also have to educate them on formula feeding. And should they decide on formula feeding, we should say, hey, it's okay. We will support you in whatever you decide to do. But we really, if we can educate them on the benefits of breastfeeding, perhaps they will go ahead and breastfeed. But we also, like I said, need to support them if they decide not to breastfeed. You should, people say, oh, you need to rub them, make them tough. That's not going to help. You should not do anything other than have your breast checked to make sure that the nipples aren't introverted. We also have dental health. A lot of dental caries, infections in the mouth can cause preterm labor. And so now we are actually making sure that our pregnant women get good dental health. Physical activities, make sure their posture's good, make sure they get plenty of rest, be sure they're bending their knees, doing good body mechanics. Physical activities should not be strenuous, but it should be enough to make them have a feeling of well-being. Of course, if they have any complications, that they're on bed rest, then we are going to have to change our plan. Most people can stay employed all the way up till their water breaks and they come in and have their baby, but it depends on where you work. So if they work in an area that is detrimental to pregnancy, then they may need to leave that employment as soon as possible. But most of them can usually leave early. Now, teaching this, there's a self-management again, posture and body mechanics to prevent or relieve backache. So there's a lot of things in there you can teach your patient to do if they come in complaining. about back pain. And if you'll look at the pictures in there, they are definitely more explanatory than me just sitting here saying it to you. So if you look at all the pictures that they tell you to do, I especially like the one where they lay on the back and put their legs up on the wall. So you also need to make sure you're teaching them about safety, such as putting on a car seat. When you're putting on the seat belt, you want to make sure that they know that that seat belt goes up under their belly and not over their belly, because it's dangerous for the baby. Clothing, they should wear clothing that are comfortable and fit. They should not be too tight. Never wear anything tight, because it can actually increase the risk of vaginitis and heat rash. We do have maternity bras they can buy, but they don't necessarily have to. Traveling is usually not indicated. Traveling restriction on traveling is not usually indicated unless there's some type of complication in the pregnancy. If they are going on long trips, they should stop and stretch their legs, do some deep breathing so that they don't develop any type of problems, such as developing DVTs because they sit too long. So they need to get out and walk often, usually about every hour or so they should get out and walk. If they're going to a country that's at high risk, they really shouldn't go there. Immunizations, we definitely want to be sure that they don't get any live or attenuated live vaccines, viruses. So they shouldn't be getting nasal flu vaccines. They should get IM vaccines. Anything that's live, they should not get. And that's why we don't give them the rubella and the MMR before they deliver, because they don't need the live vaccine. We wait until after they deliver to do that. The varicella. The pertussis vaccine is not a live vaccine, so we can actually administer that during pregnancy. And because we've had increased outbreaks of pertussis, we are now recommending they get pertussis during pregnancy, and everyone in their family gets a pertussis vaccine. Of course, we should teach them to avoid alcohol, cigarette smoking, caffeine, and drugs. No amount is good. And if they do smoke and they do drink, we need to help them, introduce them to some cessation programs that are available for that. So our normal discomforts. Normal discomforts, of course, would be abnormal in a non-pregnancy state. So there's a lot of different things that they can seek out. Acupuncture is one of them, but I don't know of anywhere in Batesville that they do acupuncture, but they do massage. So massage is really a wonderful thing. Imaginary imagery, aromatherapy is really good. Of course, don't let them take the long tub baths with oils and things in their tubs, because that is not good for their urinary infection. So on page 327, you've got this box that has discomforts of pregnancies and warning signs, and what to do about some of the things that you want to do. And this would actually go with your diagnosis when you go to OB, such as anxiety related to deficient knowledge, in which basically you're not supposed to say that. It should be anxiety, it should be either deficient knowledge related to scheduling of prenatal visits or imbalanced nutrition. So you've got things in there that you want to keep this little box in mind when you go to OBS, because you may be wanting to do some of that with an antepartum patient. You definitely want to be sure that they know how to recognize preterm labor. So you want to teach them the signs and symptoms of preterm labor. If they start having contractions, and they give you a little box for that as well. But we're going to talk more about that when we get on into labor and delivery. Sexual counseling. Some people actually believe that having sex is detrimental to the baby. They may harm the baby in some way. Little box there tells you all things you can teach them about sexual counseling. There are some changes. May make having sex undesirable in the first trimester. Second trimester, they usually Most women have an increased libido and want to have sex more often. And then the third trimester, that usually decreases. Although I did have a patient come in and tell me that when the door was shut, be sure that I knocked really loud because they maybe have sexually intercourse during the labor process. So you never know. So you want to continue to be sure that they have, that they use their history. Be sure that any misinformation they have, that you talk to them about that. And if they're, are at risk for preterm labor because they have an incompetent cervix or something, you are going to have to do some counseling over that. Psychosocial support, we fall kind of short on that. Esteem, affection, trust, concern, cultural and religious responding. We don't usually do a lot of that, but we really need to increase that. Variations, we've talked about variations, cultural variations, a lot of variations in your culture. How women handle pregnancy depends on the culture that they were raised in. So some cultural variations that you are going to maybe run into would be, I thought they had a box in here, but some of the things you may run into. Some women consider it's just a natural process. They're going to do it without any help whatsoever. Americans' culture, a lot of us are like, I'm not going to hurt at all. Give me the epidural before you break my water. Um, you know, so it really depends on their culture, and many things affect them. The subcultures, lack of money is going to help, be a big thing on prenatal care. So um, most of our cultures regard care from a healthcare professional to only be necessary when we're ill. So during pregnancy is considered normal. So a lot of time Western's medicine, especially Western, view of problems in pregnancies differ than that of other cultures. Some of them have taboos. There's some prescriptions and proscriptions regulating women's emotional responses. There's a lot of funny things. If you really looked up some of these cultural beliefs about pregnancy and what occurs in them, there's a lot of things that, some men don't believe they should be in the labor room, and some women believe their mother should be in there, and that the male should be outside. There's a lot of different things. Some of their cultural prescriptions involve forms of magic. Mexicans believe that pregnant women should not be allowed to witness an eclipse of the moon because it would cause a cleft palate infant. Earthquakes may participate preterm birth or miscarriage. Pregnant woman must not ridicule someone else. I remember as a child is that you shouldn't make fun of that person or your kids will look that way. So there's all kinds of different things that can go on with that. Physical activity, clothing, we've already talked about a lot of that. Talked about sexual activity. Age differences, there's a lot of difference between an adolescent being pregnant and someone who is older than 35 years pregnant. So there's special considerations in there. Teen pregnancy has declined since the 1950s, but we're still at the highest rate of teen pregnancies, which really surprises me since we have a lot of these older men marrying these 11-year-old girls and younger over across in the third world. But the adolescents need special care, especially in nutrition and education, because they're actually very teachable. They just don't know these things. So the best breastfeeders I ever had were teenagers. And then women over 35, they've decided to start their family late in life. Usually they're likely to be healthy, well educated, and of course of a higher socioeconomic because they've waited till later in life to have their babies. Women who have multi-pregnancies, multi-fetal pregnancies, there's usually a high risk for preterm birth. The likelihood of them having a multi-fetal pregnancy is if they have a history of dizygotic. Remember what we said dizygotic twins are. Use, of course, of fertility drugs. We mentioned that. Their uterus is going to grow quite rapidly, so they're going to start having those Braxton Hicks a lot sooner. Polyhydramnios develops easily with twin gestation or more multifetal. And usually the diagnosis of multifetal is a little bit of a shock to most parents because they were wanting one, they end up with more than one. So multifetal pregnancies can cause a lot of outcome, a lot of high risk after delivery as well as during delivery of hemorrhages. And so we take, and we have to, of course, do fetal monitoring or fetal assessment on more than one baby, and it makes it a little bit harder to do prenatal care. Prenatal education. We have classes for expected parents. So what you really need to know about prenatal education is that they can go to prenatal classes, but if they're 28 weeks pregnant, they certainly don't need to be going to an early pregnancy class. If they're only 6 to 8 weeks pregnant, they should go to an early pregnancy class. So be sure you know what class and what they teach in each class, such as the early pregnancy classes, fundamental information. They provide fetal development, changes in pregnancy, how emotional and physiological changes, sexuality, and nutritional needs. Then when they get into the mid-pregnancy, they're going to concentrate more on possibility of breastfeeding versus formula feeding, infant care, how to take care of themselves hygiene-wise, how to take care of all their discomfort, safe remedies to use, and so forth. Then, when they get into that late pregnancy, they need to learn more about birthing and coping with labor. So those are, you wouldn't want to start teaching someone about how to cope with labor if they're in early pregnancy. They're not ready for that. So all prenatal education programs should meet specific learning needs. If you have adolescents, if you have older women, if you have multi-paras, hearing, you should always have those issues in mind for those. We have a lot of choices. Actually, pregnant women do have a lot of choices in how they're going to receive their perinatal care. They can actually, whoops, did that go backwards? Okay, so they do have a lot of choices. They can go with an OBGYN or a regular family physician that delivers babies. A lot of people feel more comfortable with a doctor. Midwives are wonderful. There's different types of midwives. There's the certified nurse midwife, there's the direct entry midwife, and the lay midwife. The certified nurse midwife is an RN who's gone on and become a midwife. The direct entry midwife is someone who has entered into a school of midwifery that does not offer a certified nursing midwife, but they have gone in and learned midwifery and received a degree from it. The lay midwife is the person who went with the lay midwife before her and just learned how to deliver babies and be a lay midwife from simply doing. They have no degree and they really are not held accountable, as much accountable for things that go wrong as a certified nurse midwife. But a certified nurse midwife can actually do inductions. They can order epidurals. They can do a lot of things that the doctors can do with their patients, whereas a lay midwife cannot do anything except be there and laboring the patient, helping them with their discomforts by, and I'm not saying a lay midwife is bad. I've seen several good lay midwives. I've seen several bad lay midwives. So, and depending on what you want, a lot of times some women like to deliver at home, and there's still not very many people, nurse midwives or doctors that will deliver at home. It's just not safe, according to most people. And it's not really safe when you consider all the equipment and stuff you have available at a hospital or a birthing center. Doulas are kind of cool. Doulas are not, you can get certified, you can get educated in doulas, you can be trained as a doula. But doulas are the ones that are going to help you get through your pregnancy. They're going to help you with your discomforts. They're going to help you emotionally, give you informational support. But they don't do any type of clinical task inside the hospital setting. Um, Continuous support of a doula is actually shown to decrease the use of pain medication. Some people look at a doula as being a substitute for the husband as a coach. But sometimes husbands just want to be there and hold their wife's hand and get through this labor. So a doula is actually pretty helpful in knowing what to do to help them get through labor. So doulas can be hired. They are in it for not only for being able to help with the pregnancy and the delivery, but they're also in it um, to help themselves financially. They do get paid for it. Birth plans. I used to hate birth plans. I thought they were the bane of everything, but really women should have a plan A, B, and C. Go in expecting what you want, ask for what you want, so that so the nurse knows, the doctor knows exactly what you would like to see come out of your happen in your delivery. Also be prepared that things happen. Babies do not always cooperate, and you should have a plan B and a plan C in case your birth plan does not work out. And you and your nurse and your doctor should discuss what all you think you should have in that birth plan. Of course, should you have the baby in the hospital, a birthing center, at home? Personally, I think a birth center would be awesome because you don't have all these other medical patients that are in the hospital and possible contamination from other areas. And it's all about pregnancy. It's all about the baby. And it's all about doing the best and having the best route that they're the ones that are going to go by your birth plan. They're the ones going to try to help you have your labor and your delivery the way you want to. Home births are a little bit at risk because you don't have any resuscitative equipment. It's very popular in a lot of other countries, but in the United States, less than 1% of the births occur in home births, simply because there's just not hardly anybody that wants to take on that risk, because we are a Sue Happy nation and nobody wants to take that risk on. Hospital, you're definitely going to get everything and anything you want. They're going to they try to offer LDRP rooms where you're comfortable. Things are private. Try to have the same staffing that you throughout the whole stay, and have they usually have fetal monitoring and things that are necessary in case of emergency. And freestanding birth centers, usually located close to the hospital in case they need to take someone over there for a C-section. Usually certified nurse midwives run birth centers, and they usually only take low-risk patients. The emergency equipment's there, but they can't perform a cesarean. You can attend attendance at birth classes and parenting classes are required. They develop their birth plans. They're very supportive of that. So it's basically whatever you decide that you would like to, where you would like to have your baby.